Hi, my name is Mike Hayton. I'm an orthopaedic upper limb surgeon and I'd like to talk to you today about ulnar nerve entrapment. The ulnar nerve, or perhaps more commonly known as the funny bone nerve, is a cord-like structure that passes behind the elbow. Occasionally when we bang the inside of the elbow, we get this sharp electric pain that radiates down into the little finger and the ring finger, and this is the ulnar nerve that's been injured. But in some patients, the ulnar nerve can be trapped behind the elbow through a variety of causes. Usually this is by a sheet of tissue that presses on the nerve. In the vast majority of cases, we don't know why they get this condition. But fortunately, there is good treatment to be available. Patients present with pins and needles and an altered sensation in the little and the ring finger, both on the front of the hand and on the back of the hand. This also affects the inner border of the forearm, and often they will have some discomfort around the funny bone area of the elbow. Symptoms can often be worse at night. As we sleep in the fetal position, this puts a stretch on the nerve and causes increasing pressure. Your doctor will ask you about these symptoms. Your doctor will then examine you. If I show you on Sandra's elbow where the ulnar nerve runs. The ulnar nerve runs from in the upper arm behind the funny bone along the border of the arm. Occasionally we perform a Tinel sign, which is where we tap on the nerve, and the area of irritability behind the elbow can often be identified. The ulnar nerve can actually be palpated as a tubular cord-like structure and can be sometimes very tender in patients. To increase the pressure on the nerve at the cubital tunnel, we can ask the patient to flex the elbow forward, and this puts the nerve onto a real stretch, increasing the pressure. And within 30 seconds or so, the patient may notice pins and needles in their little finger and their ring finger, both on the front and the back of the hand. As soon as the patient notices those symptoms, I relax the nerve to prevent them causing them more discomfort. Thank you, Sandra. Along with sensation, with decreased sensation in the little and the ring finger, the ulnar nerve is extremely important to provide power for the hand. And the small muscles of the hand are supplied by the ulnar nerve. In particular, patients may notice they've got weakness of holding their fingers apart. They may have an inability to cross their fingers. But in the early signs, patients just notice that their hands feel clumsy. They just can't pick those small, intricate objects that they previously could perform. How are patients with cubital tunnel investigated? Well, often we'll perform nerve conduction studies, and these can be performed by a neurophysiologist who will apply small electrical pads on the tips of the fingers and record the electrical speed of the nerve up and down the upper limb. This will be compared with the opposite side, but in cases where the patient has this condition in both arms, will be compared with the normal population data. The vast majority of patients with cubital tunnel syndrome hopefully will settle within a few weeks. But if this continues after 6 weeks, and in particular, if the patient notices motor power and weakness in the hand, such as clumsiness, we often recommend surgery. Surgery is performed usually under general anaesthetic as a day case, and a small 5 centimetre incision is made on the inside of the elbow. The soft tissues are reflected to try and find the nerve. Once the nerve is identified, it's released under direct vision along the line of its direction. The wound is then closed with a dissolvable suture under the skin, and butterfly stitches such as steri-strips are applied. A bulky dressing is applied to the arm, which is in place for 2 days. After the 2 days, this bulky dressing is removed and the steri-strips are kept clean and dry for a period of 10 days. After this time, I ask my patients to perform more or less normal activities. Indeed, I don't like elbows to be kept still for more than 2 or 3 days, and I'd encourage patients to go through an early range of movement. Of course, with any surgery, there are complications. Patients may not get complete resolution of symptoms, particularly if the nerve has been permanently damaged through long-term compression. Other risk factors include infection and damaging small blood vessels and nerves that may cause numbness over the tip of the elbow. But in the vast majority of cases, I quote a 90 to 95% success rate with this surgery.